Hello everybody, welcome to this Talking Tendons podcast. My name is Peter Maliaris. I'm thrilled to be joined today by Colin Griffin, who is a strength coach and clinician who deals a lot with Achilles patients from Dublin in Ireland. We had a really good chat and it could have gone on for a lot longer than what it did, touching on some really important aspects of Achilles rehab. I hope you enjoy it.
Colin, welcome to the podcast.
Thank you, Peter, for having me on. It's a privilege to be part of your podcast.
No problem at all, mate. It'll be great to have a chat and talk about some of our shared interests. So I just wanted to start today by, if you can just give us a bit of a rundown for people who don't know you. Obviously, you're starting to make some really good inroads into some tendon research, and obviously you're a clinician as well. Do you want to give us a bit of a background about yourself and what you're doing at the moment?
Yeah, sure. I'm based in Dublin in Ireland. I work at the Sports Surgery Clinic. I'm a strength and conditioning coach, but I'm clinical lead for the foot and ankle rehabilitation stream in the clinic, and also a PhD candidate affiliated to University Côte d'Azur, but also working in a close partnership with the Sports Surgery Clinic, looking at Achilles tendinopathy and rehab and lower limb biomechanics. So working under Professor J.B. Morin in University Côte d'Azur and Dr. Andy Franklin-Miller in Dublin. So yeah, I've been working at the Sports Surgery Clinic for the last, actually just thinking it's 8 years now this month, so I don't know where the years I've gone to. So prior to that, I had a long career in elite sport. I was an international athlete, 50k race walker, represented Ireland from international level, from junior right up to senior, and up to 2 Olympic Games in the 50k walk. So I've had a good background in sport. I've been there as an athlete who's had injuries of all sorts. I've also been involved in coaching, and so I suppose, yeah, I suppose I like to think I come at it from a broad base, or a broad background.
That's really interesting. That is a really interesting background. Have you ever had an Achilles problem yourself?
I did, yeah. In my early 20s, I had maybe 2 flare-ups, but I suppose it wouldn't be most common injury in race walking. You don't have the same stress shortness cycle loads as you would during running. I just had 2 flare-ups, but I suppose if I knew back then what I know now, I suppose I would have treated differently. But
yeah. Very good, Colin. Thank you for that. We'll talk about, you're working with some great people. We'll talk more about that hopefully later. Tell me about, so in terms of your mix, you're obviously very busy. You're doing a lot of your clinical work and your research. What do you do just for the interested sort of young budding clinicians, maybe people who want to get into research? How do you mix your time up between the clinical work and the research work?
Yeah, so I suppose we're lucky where we work in the clinic, where they're very supportive of. They put a big emphasis on research and very supportive of PhD projects or PhD programs. So, good few of my colleagues have done or are completing or have completed PhDs in different areas. So we would have been well established in ACL rehab research through Andy King, and also he's also pioneered a lot of our research programs in hip and groin injury as well. We've a shoulder research program going, concussion, anterior knee pain rehab. So mine was a little bit more, probably the first looking more around the sort of lower limb, foot and ankle area, and I've always had an interest in tendons. It's one of I suppose when I started working in the clinic, I was dealing with a lot of lower limb running injuries. I like treating tendons. I suppose I gained an interest in the research in that area, and I suppose started to establish my own principles of rehab, which we'll talk about later. So yeah, like I'm in my 5th year of my PhD program, a little bit longer than I set out. But we have a 4-day, 1-day sort of clinic research split. So 4 days clinical work and then 1 day of research work, which is, I suppose, has its pros and cons. I suppose that the benefit is we have easy access to recruit participants for a study. We've got good lab support, good supportive colleagues who've got expertise in areas that I mightn't have. So that kind of complements what I need, I suppose, in terms of data processing, stats, and all of that. Good admin support. But I suppose the flip side too, when I'm trying to, especially going through a period now when I'm wrapping up my thesis, I like to work in long, big blocks of time, and I want to do some productive writing, and that's a bit of a challenge at the moment, along with 2 young kids. But anyway, that's a complaint. But yeah, look, it's challenging. I like it.
Yeah. That's great, Colin. Sorry to interrupt. Always, I was just
You're
going to
okay.
say, always very challenging to finish off a PhD, and you sort of underestimate the amount of writing at the end. My advice is take a chunk of time off, negotiate with your
Yeah.
bosses, take a
Yeah.
chunk
Yeah.
of
No,
time off,
that's
do some writing if you can. But that's great.
yeah.
You're doing, a fair bit of clinical work. You're seeing lots of patients. So what I really am interested in these podcasts is how you approach tendinopathy. So I wanted to ask you some questions about that, just to lead into the key part of the podcast. What do you mainly see, and just describe for us what is your sort of approach to, in very general terms, tendinopathy. What do you see yourself focusing on?
Yeah.
What things work for you?
Yeah, I see a lot of lower limb tendinopathies, predominantly Achilles, but I do see a lot of tib post tendinopathies, patellar tendinopathies, proximal hamstring tendinopathies, glute med tendinopathies. So a lot of lower limb ones, but predominantly Achilles. And look, I guess we also work with a mixed population background. So we work with a lot of elite athletes, field sport and track and field sport athletes, recreational sports players and runners, and also general population as well. So it's a good mix. I definitely learn a lot from all different backgrounds. I definitely have to modify my approach. When I'm dealing with someone who doesn't come from who just wants to play golf 2 times a week and has a sore Achilles, versus someone who wants to qualify or compete in a major championship on the track. So I definitely have to modify my approach and how I go about doing things.
Yep. So you're seeing a broad range of people, a lot of love. It sounds like my clinic, actually. Sounds very, very similar to my clinic. That's great. That's a nice mix of people there. In terms of some of the specifics, so you mentioned you'll vary it, and it's obviously very individualized. It will be depending on the person and their goals, and you're a strength coach. So I want to know, what sort of approaches do you use? Obviously the evidence is quite wide open. We don't have a single best approach. How do you navigate that? How do you present the evidence to your patients, and what do you generally find yourself doing in terms of rehab? So if you can tell us about how you sort of implement the rehab and progress it, that would be great.
Yeah, of course. Look, and as a strength coach, I suppose I'm going to have a natural bias towards that side of things. And I guess I would see my remit as making sure that a lack of strength, a lack of capacity, a lack of plyometric ability, or poor biomechanics is not the main limiting factor to progressing that through their pathway. So I try to tick those boxes off. So I make sure we do a good physical assessment. So we'll assess their calf strength. So we've 2 protocols that we've kind of fleshed out over the last couple of years from trying different things. So we would do like a standard prone straight leg isokinetic dynamometer test at 30 degrees a second, getting a measure of total plantar flexor peak torque. And we also just take into account dorsiflexion peak torque as well, just for overall ankle coordination. And I suppose with the database we built up over the years, we try and set thresholds based on the sport that athlete performs in, and the level they're at, and I suppose compare them to healthy, uninjured, or fully rehabbed athletes. So we would be looking at peak torque relative to the body weight. With, say, for a recreational runner, we would expect them at 30 degrees a second to produce peak torque of around about 130, 140% body weight. And maybe like a elite distance runner to be getting up to 160, 170% body weight, and maybe a sprinter or a field sport player who competes at a high level, maybe to be hitting 200% body weight or twice body weight at peak torque. And we also look at peak torque. We run a code where we look at torque at different ranges along between 30 degrees plantar flexion and 10 degrees or 20 degrees dorsiflexion. So they may have good symmetry in peak torque, which occurs in slight dorsiflexion, but they may have big deficits in range plantar flexion, particularly after post-Achilles rupture or post-Achilles repair. It takes a while, as you know well, to chase back. So we can maybe be a bit more targeted at a rehab. So that's one strength test using isokinetic dynamometry. Then we also do a seated isometric, seated calf isometric test as well over the force plates. So we seat them with a knee at around 90 degrees, slightly positive shin angle, the base of the first met on a slight block, and set them up in dorsiflexion. So about 20 degrees dorsiflexion, put a ratchet strap around the knee, and then they maximally isometrically push for 5 seconds, do 3 trials, and get the best out of 3. That seems to be very convenient because a lot of clinics and universities have force plate technology that are a bit more accessible and affordable these days. So it's just a nice, quick way to measure, particularly solace peak force. As we know, when we bend the knee close to 90 degrees, we're giving the solace nowhere to hide. So, and
that's fantastic. Can I just ask about that? That's a really nice. They're really nice two measures because you've got one dynamic one, you've got one, through range, and you can see, as you say, the plantar flexion deficits if they have some, and you've also got your isometric measure. That's really a nice mix. Do you have, with your force plate measure in seated, do you look at just the peak force, or do you then convert that to some torque, because then you've got them in sitting and you need to work out the moment arms? How do you guys navigate that?
Yeah, for the moment we just look at peak force. We haven't got the means yet to properly work out the moment arms, and well, we could, but we just haven't at that layer yet. So as part of my PhD thesis, I have one little reliability study on that particular protocol. So yeah, we look at peak force, scale it to body weight, and again, anything upwards of 1.5 to 1.6 times body weight will be acceptable for people who want to get back playing sport at a recreational to sub-elite level. For maybe sprint type athletes or sports where there's a lot of acceleration required, where we know solace is a big player, we would be looking at maybe more than twice body weight of peak force, relative peak force. But we set them up from about 20 degrees dorsiflexion, where we know that the force length relationship of the solace is maximized.
They're going to be stronger. They're really great measures. That's very interesting. In terms of, so for clinicians listening to this, and you mentioned that these things are accessible. Your force plate is probably quite a sort of accessible one. I imagine would do the job for this purpose. Is it time consuming?
Yeah, so normally when we see someone first, we put them through, we've got a lab appointment, so we allow 90 minutes, we do a full battery of tests. I'd also just forgot to say as well, I also do a heel raise endurance test. So, like looking for like 1 second up, 1 second down with good strict technique, strict control of the rear foot, pushing through first MTP joint. And when either heel height or tempo starts to diminish, we cut it, and we'll be looking at 30 reps in 60 seconds as a good measure of calf endurance, or minimum 25 and 50. So we kind of have like a spectrum. So they may have really good peak torque. We got some people who might have good peak torque or peak force, but may have poor endurance, or vice versa. So we have we're able to get a good profile of both ends of the spectrum. So yeah, we would do those sort of three tests, like so the two sort of the isokinetic dynamometry test, and then the isometric test, and then an endurance test. And then we also look at reactive strengths, doing like a vertical and single leg, a vertical drop jump, single leg, and also single leg horizontal rebound.
So just go through those again, Colin, a little bit.
So a drop jump
for my morning brain here. So you do a vertical drop jump and
and a single leg horizontal rebound.
So that's dropping off
20 centimeter or 25 centimeter box, and rebounding for height and short ground contact
fantastic
time.
So you're looking at the contact time. That's really great. Jump height, and you can also look at the contact time on the mat.
Or the
what
force
else
plate,
or the plate. What else what's the second one that you do?
Single leg horizontal rebound test. So that's another study that I've doing a reliability study on that for my thesis. So basically they stand back from their force plate, they self-select their distance, hop on one leg onto the force plate and rebound with minimal ground contact time for distance. So it's a horizontal reactive strength measure, but as we know from some of the modeling work, horizontal rebound or horizontal hops probably have the highest loading rate on the Achilles tendon. That's more comparable to high speed running, probably a little bit more so than vertical hopping. So it probably gives us a good robust measure of the tendon's readiness, or the muscle tendon unit's readiness to return back to competitive sport. Now, we wouldn't do that test, on someone who comes in for initial assessment, because they're going to be sore, the pain's going to inhibit them. There may be a big element of kinesiophobia. So that's something we might maybe not do until maybe mid-stage or late-stage rehab.
That's great. Would you be looking to do some of these tests, some of the reactive tests, when someone is completely pain-free? Is that when you would want to do them, just to take out the pain from the equation of sort of impacting on their findings?
It depends. Like if if they're not too sore and it's still able to do a little bit of running, well, look, I'd be happy enough to at least do a double leg drop jump and then a single leg drop jump, and then if they're up to it, we'll have a go with the single leg horizontal rebound. But if they're very sore, if it's really reactive and it's early, we would hold off on that and maybe just do the strength tests. That might be a little bit safer and more tolerable, and then maybe look at the more dynamic stuff a little bit later on when they're more settled.
That's look, that all that stuff is really good, and I think the rehab for Achilles, and I guess for a lot of conditions, should move towards clinicians in the clinic utilizing some of these accessible equipment. You can get jump mats that can measure some of the contact time variables and also height that you're talking about, and it's really a positive thing to do. So that's great that you're starting to publish some of that. I look forward to some of that work coming out soon, hopefully. How do you, Colin, just then take it to so you've got all these outcomes and you've got a really good idea where your Achilles patient is. How do you then target the rehab? Is there any ways that you target the rehab towards certain things? Say they're missing reactive strength, or say they're missing a bit of endurance, or or is it like a set rehab that you guys do and you'll just target everything?
Yeah, look, I have a broad model, but it's very much individualized. I try not to work in blocks too much. I try to because sport is complex, so I might have a few little qualities that I'm trying to develop at once, but one might be a priority for a moment in time. So it may be calf capacity might be a priority early on, but I may still start the process of bringing in some reactive strength, doing some low amplitude double leg pogo hops just to start that process if they can tolerate it. But again, so I suppose it's just trying to find the right entry point and focus on what's the biggest priority for the athlete or patient in front of me. If it's a really sore, painful tendon, they can't do isotonic calf raises, but they can tolerate isometrics. I'll start them on isometrics. I know there's a bit of a debate in that about its potential efficacy in terms of its pain modulation. I have a probably
there's no debate. There's no debate. It doesn't work.
Yeah, well, yeah. I suppose.
I'm being a bit facetious. I think you're absolutely right. It's an individual approach, isn't it?
Yeah. I don't waste too much time on it, but if I give it to someone as a warm up and they feel a little bit better afterwards than they did beforehand, well, then I'll just I'll keep it in the program just as a warm up. But as soon as I can go on to the more dynamic stuff, I won't waste time. I'll try and progress them on. I think momentum is important early on, getting some early wins, getting the weekly structure right, educating them about pain. It's okay to be a little bit sore. We use that sort of yourself the NRS. So 3, 4 out of 10, we're okay with that. If we're no more than 5 out of 10 the following morning, but it eases as the day goes on, that's okay. If you wake up 2 days time and it's better again, that's ideal. The tendon just needs that day or two to recover and adapt. And once we respect those windows, we want to progress on the next time. If it's a bit too sore, then we need to dial back a little bit or allow more time to recover. So again, just trying to get those get that set up properly from the start, and again, just look for some early wins and get some momentum. So
can I ask, do you get a lot of your patients with Achilles? Do you get them to rehab in a gym setting, or would you get them to do home stuff, or a bit of a combination?
If they have a gym, ideally yes, because obviously they can load it heavier. If they've got a gym that has access to a sit machine or a leg press, that would be ideal. We can load heavy, or when we get to that point, we can go heavy, really heavy isometrics, short repetitive isometrics, and really heavy eccentric overload in a safe way where you're stable. So particularly for late on, maybe at the start for the first few weeks, if they've got some weights at home, we work with that if we're trying to build capacity and do some basics first. But I might say to them, maybe look, if you come back to me in 2 or 3 weeks, if you can if you get access to a gym that has a sit machine or leg press, that would be ideal. And if they do, then we can definitely make a lot of good progress. But when we learned from during the initial stages of the pandemic when gyms were closed in Ireland, I'm sure it was the same in Australia, we were able to improvise and get a good bit done at home. So we find ways if we're challenged that way. Yeah,
no, for sure. And how often would you then, because obviously strength is and your sort of the defined outcomes that you've talked about are really important for your rehab, and I think that's I also agree that's really important to have some goals that you're working towards. How often would you would you reassess these things with people? So you set some strength targets, I imagine. Would you then sort of reassess them at certain times?
Yeah, so I would try and, for the first maybe 2 to 3 appointments, I'd probably try and see them maybe, 2 weeks apart. And then once they start to make some progress, and again, I want to try and transfer some independence to them as soon as possible. And once they feel that they're in control of it, and we might maybe spread out the appointments a little bit more, but maybe around the 4 to 6 week mark, we'd reassess them again, do a full lab test, and see if we get those changes. And then if they have seen some tangible changes, numbers don't lie, well then you get good buy-in that way. They're confident. They know the purpose of what we're trying to do. And if we're anyway short, then we can probably narrow it down and focus on whatever little gap it is that needs to be filled before they get back to playing the sport or activity they want to do.
In your experience, the ones that are not quite hitting those marks, what are the key reasons?
Yeah, it's not all plain sailing. I'm not, so you got to look a bit wider. Probably the older population, where there might be a little bit more maybe systemic factors, metabolic, issues. They can be a little bit trickier, take a bit longer. In some cases, some of them, when they haven't properly exploited strength work and load of rehab, there can be a good window there to make some good wins. So, but there's some that can be a little bit more stubborn and take that a little bit longer. And there might be other, as I said, metabolic factors that might be affecting tendon metabolism and their progress. So that's a bit of a long game, and a lot of education, maybe a little bit more psychological support as well. And maybe trying to, I suppose, create a better environment for them to rehab and to look for those small wins and try and build momentum from that. So yeah, they can be tricky. And again, it might be a little bit slower with them too. Maybe not trying to push heavy load too much. Maybe just try and keep the loads a bit more moderate. Go for a little bit more capacity work. Trying to give them a good sort of metabolic stimulus as well. And then just probably try to educate them more on diet and I suppose good lifestyle habits.
Fantastic. That sounds very, very sensible. Just finishing up now, Colin. Just a couple of last things. Just wondering about. And obviously you've got this real, strength and increase in capacity approach, which I was really interested to hear about. And I'll ask you just briefly about your trial in a second. What do you do? And you probably touched on this partly, but are there any other strategies you use for buy-in and adherence? Would you say for sometimes just get people just get them in the gym and say, look, you need to be supervised. Maybe not. That's not a very patient-centered way to talk to people, but you know what I mean? You might be sort of thinking, some people, you might encourage them to have a supervised approach because they're just, not seeming like someone who's going to be able to undertake the work. Is there any tips you have for, buy-in and adherence?
Yeah, so we in the clinic we have an app that we've designed in-house. So we prescribe a program on that. They have their program of exercise, they have the targets, they have a video demo that we would record them as they're doing the exercises. So they have a demo with some verbal cues on technique and how to execute the exercise. And then they have an option then to log their progress, to log their exercises, so the sets and reps and the load lifted. So that works well for some people. I think what works best too, and again, we'll probably touch on this when we talk about my study in a minute, but people have often come to us having done, say like the Alfredson's protocol. And again, I don't want to sound dismissive of any other protocols because people have done a lot of pioneering work in this area with the best of intentions, but people just probably find it hard to motivate themselves to do X amount of heel raises every day, bent knee, straight leg, on a daily basis versus going to the gym 2 times a week, doing something short and sharp and intense, getting a good sort of feel-good factor from it and feeling some progress and having time to recover. So that's why I find I get buy-in, I get better buy-in from, and hopefully my study will maybe flesh it out a little bit more.
No, sounds good. Tell us a little bit about, just before we finish now, tell us a bit about your study. So you are doing this trial. Do you want to just tell us a little bit about where you're at with it and what you're testing exactly?
Yeah, so I suppose I've the training. So basically we're looking for, we've powered for 50 participants, so 25 per group. So the training group would follow the program that we've kind of devised over the years that I put together. So again, along the lines that I talked about, that we'll assess them at the start. They'll come in at whatever level is appropriate to them, and we'll be guided by, I I suppose, the targets they achieve in their exercises. And like, we're not going to be totally driven by pain. So look, we'll ask them to exercise to, I suppose, a maximum tolerable level of pain. But we'll also be trying to achieve a certain percentage body weight of load lifted or whatever. So we have those targets in there. And then when we come to the plyometrics, we'll use our hop test then to guide us there as well. So it'll be 2 to 3 sessions a week, 3 sessions a week at the start for the first 6 weeks. And when they're back running a bit more, it'll be back to 2 rehab sessions a week. So very, very load focused. The control group then will follow Silbernagel's protocol, which is like the daily program of exercises, guided primarily by pain. So we thought it was probably a more suitable group, a suitable control, given the multifaceted nature of our rehab program. So we have a different physiotherapist supervising that group. So they come in, they're blind, they're assigned, they do their baseline test, and they're randomly assigned to one of the 2 groups. They check in every 2 to 3 weeks for a supervised rehab session. We retest them again at 6 weeks and at 12 weeks, and then we do a 6-month and a 12-month and also 2-year follow-up. And we're using the Visa A questionnaire as our primary outcome measure. And then we'll also do, at 6 months and 12 months, we'll do the patient satisfaction questionnaire and global rating of perceived change questionnaire as well, which I think is important.
That'll be fascinating. That'll be absolutely fascinating, because it will just help to answer so many questions that we have at the moment in terms of, do people actually improve with some of these outcomes that you're testing, like the hopping and reactive type outcomes and the strength and everything else, and also a comparison between 2 programs that are, your program obviously you've built up and is quite individualized and really sort of high end, and then you've got the Silbernagel program, which is also a reasonable program and does show positive effect. So it would be really interesting to see what that shows. When are we going to see the findings of that, Colin?
Yeah, well, look, I mean, I hope to have enough data collected by the summer to have because obviously I've got the protocol paper published on BMC. So I'm hoping, so at least that's that's all pre-registered. I can't move the goalpost now, as you know, so it's a robust, robust study, hopefully. So I'll have enough data collected.
Have you been affected by COVID a lot in terms of data collection?
So I suppose, look, at one of our groups, the training group probably relied on gym access to do the program properly. So we did have to, at certain periods when gyms in Ireland were closed, we just kind of paused recruitment. And then once gyms reopened again, we put a big push out there to get patients into the study. So it's been a little bit of a stop-start, but I've had a good run of it now. It's the last few weeks. I've got a good intake there. So I hope I have enough to write up a good chapter on for my thesis in the summer, but I will keep the study going until I hit my 50 minimum of 50 participants, and hopefully do my 1 and 2 year follow-ups, and hopefully get a good publication in a few years' time.
Good luck with that. It's not an easy job to recruit people and keep them in the study. So well done. Lastly, so this is the last question. Tell us about, and this is a question that I want to ask to everybody as the last question of the podcast. Tell us 3 tips that you would give to clinicians, young clinicians, and it could be things that you've learned or things that you would do with tendon patients, but any 3 tips that you can leave us with. Doesn't have to be 3, actually. 3 is quite a lot, but give us a couple of pearls to end off with.
Yeah, and I suppose, look, at wearing my strength coach's hat, our body is designed to adapt. Every tissue in the body can adapt if the dose is right and if the stimulus is right. So tendon is what I call a mechanically sensitive and metabolically active organ. So obviously it got injured for a reason, because there was probably an overload or something that affected its metabolism, or inadequate recovery or whatever else. So once we get it down to a settled level, we can make the tendon adapt again. How you go about doing it, that's, I suppose, the $1 million question. So that's where we've got to try and delve into the different qualities that you can assess. See, is it a strength issue? Is it a capacity issue? Is it a tendon stiffness issue? Which again, we don't have the means to assess at the moment, but that's something that would be worth doing. If you could. Is it a biomechanical overload issue, or a combination or an interaction of those things, or is it just a training load factor? And then I suppose education then is key. And there is there's probably an irrational fear factor too when people have an Achilles tendon, that a lot of people think they're going to rupture it. I try to reassure them that, look, obviously, yes, when people do rupture tendons, as we know, there's probably signs that there is some pathological changes prior to rupture happening that we don't know about. But when you have a tendinopathy, because of the pain and the fear you have, you're unlikely to do anything that's going to cause you to rupture. So we try and, I suppose, reassure them in that sense. But yeah, I think definitely trying to promote the whole area of, graded exercise, trying to adapt the tissue and make sure there's good calf capacity, and then tick that box and make sure that they can, they got good reactive strength qualities, good coordination, and then to take that into their running and whatever their sport is. Yeah,
it's fantastic, Colin. I think as I said during this podcast earlier, I think there's some really valuable tips in there for clinicians in terms of looking at assessing things, and assessment is just so important, and having some objective data on some of this stuff is very, very important. So that's great. Look, thank you very, very much for sharing your knowledge, and for coming on the podcast and talking about Achilles tendons. I really, really appreciate it. Good luck with the PhD. Hope it ends up going well for you, and I'll speak to you soon. Thanks for coming on, Colin.
Thank you very much, Peter. Thanks for having me on.
Great, thank you.